Good afternoon, ladies and gentlemen. It is a great pleasure for me to welcome you to this booster session. I'm Dr. Yiting Xie, a child psychiatrist from NCKU Hospital Psychiatry Department from Taiwan, and I'm going to chair this afternoon's poster session. And I will introduce some basic rules. First, please limit your presentation to 1 to 2 minutes. At the end of each presentation, there will be 1 to 2 for discussion, 1 to 2 minutes for discussion. And we will cancel the poster number 7 because the presenter cannot show online today. Therefore, we have 6 scheduled posters, which were chosen as Rebound Poster Award this year, will be presented today. At the end of this session, if time is enough, we will have an open discussion on any of the poster presented. Or if someone want to present your poster, we are very welcome to. Okay, the first poster today will be presented by Dr. Virapasha Shanmugun Pallavi from India. He is an assistant professor of Rumaya Medical College, and his topic is neurohemodynamic correlate with spatial working memory in affected first-degree relatives of patients with schizophrenia. Let's welcome Dr. Rapasha.
Hi, good morning, everyone. This is Dr. Virupaksha from India, Bangalore. Do you want me to present the poster or would you play the recording?
Hey, can you see your
Okay,
poster?
may I present? Yeah. Good morning, everyone. My topic or the title of the presentation is Neurohemodynamic Correlates of Spatial Working Memory in Unaffected First-Degree Relatives of Patients with Schizophrenia. What we did in our study is primarily schizophrenia is a major mental disorder, and the vulnerability for schizophrenia is also something which is very, very critical. So we evaluated first-degree relatives of patients in our study who are brothers or sisters or siblings. So we had around 27 high-risk subjects who are first-degree relatives of the patients, and around 25 healthy controls who are both education, age, as well as handedness match. We used fMRI in our study. We used a 3 Tesla fMRI machine, and we also know that spatial. There's someone who has not muted. So we also know that spatial working memory is considered as one of the endophenotypic marker, which is consistently seen to be affected in schizophrenia. So we used a spatial memory task, that is the spatial NBAC task, as a fMRI paradigm in our study. We used both 0-back as well as 2-back. So when we compare the two groups, you can see in the results that the first-degree relatives of schizophrenia patients had a significantly in terms of efficiency as well as performance as well as time taken to respond was significantly higher compared to the normal population. And also we had certain a priori areas, prehippocampal gyrus, parahippocampal gyrus, prefrontal cortex, and insular cortex, where we found in the picture, you can see that we found that these areas were hyperactivated compared to controls. The discussion part is in high-risk subjects because of the vulnerability, because of the risk factor, and also as part of a neurodevelopmental hypothesis, we found that these people are hyperactivating the same areas much higher than the normal population. This hyperactivation is primarily because they have to put more effort to bring out the same amount of efficiency. And it is also noted that in the default mode network, patients with schizophrenia as well as high risk subjects of schizophrenia, they have a higher level of default mode network compared to the normal population. So the results are put in the table. In conclusion, what we found was patients or the first degree relatives had certain neurobiological changes which was not translated into schizophrenia symptoms. And also these identifiable factors, especially like using the working memory task as a identifiable factor in future, may help us to identify the symptoms or endophenotypic factors early and take precautionary measures so that there is no conversion of high risk subjects into schizophrenia patients. Thank you.
Okay, thank you the presentation from Dr. Pasha. Any questions? I saw someone raise your hand during the presentation. Maybe you have some question. You can speak now. Oh yeah,
Hi.
Hey, you can use your microphone to ask question.
Come again, I didn't hear you properly, sorry.
Hello?
Yeah, I didn't hear the question. Can you please repeat?
Dr. Yogesh Lai, you are talking? Okay, any other questions? For Dr. Virupasha's presentation? Okay. Okay, if there's no questions, we will move to the next presentation. Session.
Thank you.
It's on child and adolescent psychiatry training in Nepal. Early career psychiatrist perspective. I would like to call on Dr. Yogesh Lai from Nepal to present this very important subject. Now he is the psychiatry trainee in Essex Partnership University NHS Trust. It's your time, Dr. Yogesh Lai.
Yeah, can you please share my poster? Okay. Okay. Uh, Good morning, everyone. I would like to thank Revamp Organizing Committee for this wonderful opportunity to share our study. So this was an online survey that was sent to all career psychiatrists in Nepal, and with the aim to explore the training experiences of all career psychiatrists in child and adolescent psychiatry, and to understand what kind of training that the trainees were receiving. The response rate was about 83%, and what we found that more than half of them of the participants reported that they did not receive adequate training in child and adolescent psychiatry. About 70% reported that their workplace did not have any specific unit to address psychological problems in children and adolescents. But when we asked about the workload, they said that they on average they see 1 to 10 CAP cases per week. So and their overall confidence in managing such cases was quite low at around 4. And about 50% reported that the training in CAP was limited. And when we asked about their eagerness to pursue further training, 3/4 of them reported that they would like to have further training even after they finish their psychiatric training. And the most common things they would like to do is to do some kind of short-term fellowship in CAP, or get further training in psychological intervention or psychotherapies, psychotherapeutic approach in child and adolescents. Also, so despite like getting exposed to lots of child and adolescents patient in the daily practice, what we found that the training was quite limited. So this is something that we need to be aware, and most of the trainees and early career psychiatrists were quite motivated to go for further training. So this is something like as a group we thought that we could highlight to Psychiatric Association of Nepal, and bring some programs to uh, to to improve our training scheme. Thank you very much. Thank you.
Okay, thank you for Dr. Yogesh Lai from Nepal. Any questions? I think the training of the child psychiatrist is very important since I am a child psychiatrist also. I'm curious, how many child psychiatrists in Nepal now?
So there are now three child psychiatrists. Yeah.
I think maybe we have two countries child psychiatrists in Taiwan now.
Okay. Thank you for that information.
That's very. It's also a very small amount.
Okay.
Okay. Any other questions? Any comments or questions for Dr. Yogesh Lai? Okay, if no questions, we will thanks to Dr. Yogesh Lai's presentation.
Okay. Thank you very much. Yeah.
And the third poster today will be presented by Dr. Kusuma Miyanati from Indonesia. She is the junior staff in Division of Adolescent Psychiatry of Jipto Mangunsumo National Hospital. The topic is depression profile in juvenile offenders and juvenile correctional facility and the related factors. Is Dr. Kusuma online? No? Okay. So Dr. Kusuma is offline. Okay. Then here we will move to the fourth poster. Will be presented by Dr. Evidutong Eno from Thailand. But he is since now online. Also, okay, we will skip to the fifth poster. Will be shared by Dr. Rendas Rensing. Dr. Rendas Rensing, are you here?
Yes.
Yes.
Uh,
Okay, I will introduce you first. Dr. Rendas Rensing from India. He is an assistant professor of Department of Psychiatry, BKLO Walawaka Rural Medical College. His topic is assessing antenatal depression in primary care with the PHQ code of PHQ9. Can it be carried out be auxiliary nurse-made life? Okay, let's welcome Dr. Brenda Renzi.
And first, I would like to thank all organizers for giving this to present my topic. We all know the antenatal depression is prevalent, unrecognized, untreated, but treatable common mental disorder affecting. In India, the important barriers for non-delivery of mental health care for antenatal depression is human resource deficit, stigma, knowledge gap,
Excuse
and
me, Dr.
financial
Brenda,
constraint.
may you can speak loudly?
Hello.
Hello? Because the voice is quite small. You can get close to your microphone.
Hello.
Hello?
I'm audible.
Oh.
I'm audible.
Yes, more clear now.
Hello everyone, and thanks for giving this opportunity to present this important topic. We all know the antenatal depression is one of the most prevalent, unrecognized, untreated, common mental disorder affecting the woman during the pregnancy. In India, the important barriers for non-delivery of mental health services includes human resource deficit, stigma, knowledge gap, and financial constraint. Stepped care approach, that is nurse-based collaborative and integrative models, are found effective and scalable in developed country. ANM, that is auxiliary nurse midwife, plays a vital role in delivering the and child health services under the national programs. So we have tried to find whether this model is effective to screen, support, and refer or educate women with antenatal depression. So for that, we need the good data reliability among the ANM and mental health professional, so that we can the reliable data. So that was the aim of our study. And in prospective observational study carried out in rural part, we have administered PHQ-2 and 9 translated and valid version to around 108 women by two raters, that is clinical psychologist and ANM, binded to each other and calculated the kappa and weighted kappa coefficient for measuring the inter-rater reliability. We found that there is excellent and good reliability, but for items like poor appetite or overeating, the weighted kappa score was relatively low, and for the other item, that is moving, speaking, or slowly, the weighted kappa was relatively low. So ANM administered PHQ-2 and 9 had the substantial agreement and good to extent reliability with the CP administered, that is a clinical psychologist administered PHQ-2 and 9, except for these two items. And therefore the ANM can reliably screen and measure the severity of antenatal depression up to the 80% of reliability. And if we improve these two items, that is the poor moving or speaking so slowly, then the overall inter-rater reliability can be improved. And I would like to thank the Indian Council of Medical Research for funding this project under mental health program. Thank you very much.
Okay, thank you for the Renda's Renzi. Any questions? Any questions to Dr. Renda's presentation? If there's no questions, thanks for the Dr. Renda's. And the sixth poster will be shared by Van Studenten from Vietnam. He is a psychiatrist of Department of Psychiatry, Online Medical University. And his topic today is polyillicit drugs use among methadone maintenance treatment patients and related factors translational study in online Vietnam. Let's welcome Dr. Van Xuenten.
Yes, good morning, everyone. Yes, my name is Phạm Tuấn, come from Vietnam. Our results is a small part of our program to assess the effectiveness of the methadone maintenance treatment which applied in Vietnam 20 years ago. And in the assessment, we recognize that the poly illicit drugs use, which I call PIDS, it still remains. It has been shown to increase the rate of the treatment dropout, hazardous sexual behaviors, criminals. Through several observations, we hypothesize that the PIDS in Vietnam context is significant. However, there still be a lack of this data, so we decided to investigate the prevalence of PIDS among MMT patients and its contextualized associated factors. Cross-sectional studies were conducted in 5 outpatient MMT clinics in Hanoi, together with socio-demographic and other factors related to heroin use and MMT admissions. We used the alcohol, smoking, and substance involvement screening test, the ASIST, Vietnamese version 3.1, to screen the substance use status, and the depression, anxiety, stress scale, that's 21 items for evaluating the psychiatric disorders. And the result, 1,014 were eligible and accepted to enroll the research. Most of them were males and in the age of the 30s and 40s. 2/3 had a history of heroin injection, and more than 18% are in MMT program at least 1 year. The figure 2 indicated that nearly 70% will totally follow the treatment recommendation. However, the rest, roughly 30%, will still keep using drugs illegally that require brief or advanced education in previous 19 days. The surprising thing that only 25 participants, that's equally to 2.5% people, use more than 1 drugs. In this group, 21 patients used 2 drugs. The drugs were used reported based in the self-report ACID questionnaire, and we still suspect that there still be other positive cases which were not recorded. And the figure 3 illustrated the pattern of the drugs combination. Using both opioid-like drugs, heroin, and amphetamine-like substance is the prominent phenomenon. ATS is a synthetic substance with affordable price and easy to find than other kinds of drugs in Hanoi. Participants reported that using ATS gives them more energy to maintain their work. And the second prominent pattern is combining opioid-like drugs and hypnotics, particularly unprescribed benzodiazepine. They use benzodiazepine to reduce the adverse effect of methadone and improve the sleep. The figure 4 shows that the patient with the depression on that scale living in the cities and regularly exposed to the addicted persons were at risk of PIDS. Our result have the same result with other research in the other countries. Besides, we noted that who were certified with their economical status were less likely to use PIDS, and having more than 1 year in the MMT program was a protective factor. This does not conflict with other results, indicating that the more time patients follow and adhere to the MMT, the less likelihood they have problem with the drugs reuse. Finally, although the PIDS were not high as we assumed, but another research with reliable tools such as urine test, blood test to determine the drugs need to be conducted to answer more our question. As psychiatrists, we need to take care about their psychiatric and psychological status, especially the depression factors, to improve the effectiveness of the program. Thank you for listening, and I welcome the questions. Thank you.
Okay, thank you for Dr. Tang. And any question to this presentation?
Thank you, Dr. Pham, for your presentation.
Yeah, thank you.
I am Dr. Roshan Bhatt. I am assistant professor in psychiatry from India. I also one of the faculty in charge for methadone maintenance treatment program in India. So I wanted to know about what was the dose of methadone given, because what we have observed in India that if you give adequate dose of methadone, which controls the craving and withdrawal symptoms, even going to other drugs is reduced significantly. That is what our observation is. So I wanted to know that how the dose was optimized and what was the average dose given. Yes.
Excuse me, because I cannot hear your voice clearly.
Okay.
Can you type your question?
Yeah, I can repeat again. What was the dose of methadone and whether these patients were stabilized on methadone mental treatment? Whether these patients were stabilized on methadone.
Do you see the question?
Yes.
Yeah.
I see the question.
Yes.
I think you can answer.
Okay.
Dr. Tang's, and you answer the question. I think. And because of E 2 minutes this session, any other question to all the presenters? There's no questions. I see Dr. Kusuma Inayati is online now. Would you like to plan very quick in 1 minute? Hello, Dr. Kusuma. Hello. We can hear you.
Hello?
Hello. Yes.
Okay. Okay. Can I start my presentation now?
Okay. In 1 minute. Thank you.
Okay. From Psychiatry Department, Ajipta Bangunkusumo National Hospital and Faculty of Medicine, University of Indonesia. And in this great opportunity, I would be presenting research in offenders and the correction offenders. Injection, others juvenile offenders might have pessimistic involvement in juvenile offenders, and on the other hand, the course of depression or the this cross-sectional study aims to determine the depression profile and the related factors among the juvenile offenders in Indonesia. These are actually the question more level is needed for comorbidities. First, and used to most comorbidities where dysthymia interferes with non-alcoholic psychoactive substances use. There was no statistical correlation between health services and depression. Different analysis for correlation between depression and bullying, family visitation or detention period could be continued for multivariate analysis, and resulting family visitation and detention period are significantly correlated to the onset of depressive symptoms. And we also found that bullying are confounding factors for depression symptoms. And dysthymia, which are widely met, show the chronicity of depression, and according to some literature, adolescents with behavioral disorder and substance use could arise based on discomfort with the daily life, and thus was used as self-medication or as a social tool to be accepted by their peers. And several studies say that longer detention periods were related to perceptions of juvenile offenders towards familiar environment are seen as support from the facilities. Most of the respondents were visited by families during their detention period, which could be found in Asian cultures that they tend to have a closer family and better family support. And offenders tend to use bullying and abusive behavior to protect themselves from possible violence. More than two-thirds of juvenile offenders report the need for more health services during their detention. Healthcare workers are seen as more supportive, but the skill to recognize a depressive symptom itself might be another issue to overcome. And for the conclusion, this study found 44.2% of respondents experienced symptoms of depression. And juvenile offenders who have a detention period of less than 1 year and are not visited by family have a greater risk of experiencing depression. It may be recommended that the screening for depressive symptoms should perform regularly in juvenile intervention and psychotherapy. Psychoeducation, stress management training, and life skill training to upgrade their emotion regulation and problem solving skills in dealing with provocative situations that might be occurred during detention. So that they could be more self-help needed. Be
Hello, Dr. Kusuma. Thanks for your presentation. And
yes, that's all
because
for my
time is
presentation
limited,
today.
thank you.
Yeah.
And we have the last presenter from Rati Yoga Satutra.
Hello. Yes.
Hello, Mr. Randy.
Hello. Yes. Can you hear me?
Yes, you can present for 1 minute.
Okay.
Thank you.
Okay. This is my research about assertive behavior for inpatient in a nurse correlated with emotional intelligence. And as we all know, that supportive behavior can be an ideal behavior for nurses caring for patients with violent behavior. Nurses expected to manage their emotion before managing their patient, of course. And this cross-sectional study done with 125 nurses in 4 different mental hospitals in Indonesia and conducted from September to October. We find out that the mean score for emotional intelligence nurses in average level 1970% has average level, and they have a low in relationship management parameter. And the mean score for assertive behavior of the nurses is 97.5 on in average level. So this could be could not and most of them could not perform the assertive behavior. And statistical tests show that the higher emotional intelligence could perform the assertive behavior. And this is my recommendation for the should be attempt in raising emotional intelligence in domain of self-affirmation so that it could help improve the ability to behave assertively in caring for patient with violent behavior. And number two, hospital management could use the raising of emotional intelligence focus on self-emotion management so that nurses could self-internalize before carrying out nursing care. And future research expected to develop a future research using another design as well. That's all my presentation. Thank you.
Okay, thank you for Mr. Randy's presentation. And we will see session due to many thank you for your all.
Thank you.
I hope everyone can stay safe and meet you then. Thank you.
Thank you.